Hello everyone, today we're going to talk about the digestive system, the alimentary canal, and we're going to talk about the positioning and the procedures that are involved in demonstration of the large intestine radiographically. So we'll talk about examination methods, contrast media, preparation of the intestinal tract, the apparatus itself for the barium enema, and any preparation that the patient must do before the BE examination. For the large intestine procedures, we'll also talk about patient care, preparation, enema tip insertion, which is very important, a little bit about the single contrast BE and the double contrast BE. Remember, BE stands for barium enema. Single contrast, of course, would just be barium only. Double contrast would be barium and then some type of a gaseous type of contrast media, whether that's air or carbon dioxide. As it says here, it could be performed as a one or what's called two-stage procedure. Two-stage examinations involve using the barium first, and then air or another gas like CO2 would be inserted after the barium then is evacuated. For the contrast media, commercially prepared barium sulfate products are generally used, and they're used for retrograde barium enemas. Retrograde, remember, means against the normal flow. So we're putting the barium in rectally, and then we're moving the barium into the colon in a retrograde fashion. Antegrade, which would be the other way, the normal route would be cecum all the way to the rectum. We're going rectum basically all the way back to the cecum with the barium enema. We're going to use high density barium sulfate. It's going to absorb more radiation, and it's very useful for double contrast examinations. As I mentioned, air is usually used in the double contrast studies. Carbon dioxide can also be used. It's more rapidly absorbed than air would be by the body. Water-soluble iodinated agents may be orally administered when retrograde filling is contraindicated. So if you couldn't do a regular barium enema, they might give the patient iodinated contrast media to drink. Eventually what's going to happen is it's going to, water is going to be taken out of that contrast media within the colon, because that's what the colon does, it absorbs water, and you're going to be left then with an outline of the colon using the iodine. It's not the best study, and certainly, it would not be done routinely. Preparation of the intestinal tract is very, very important when you're talking about a lower GI. Very, very important. The large intestine must be completely emptied of all of its contents. If there's any retained fecal matter, it can look like small polypoid masses within the colon, which could lead to a misdiagnosis. So the large intestine has to be completely empty. That means that patient is going to follow a very restricted diet. Usually the day before the exam, it's clear liquids only, no dairy that could produce any gas. And then there is a bowel cleansing regimen that the patients would follow the morning of the exam. They're going to do cleansing enemas on themselves, perhaps what's called a fleet enema would be used. It's generally a kit that's bought at the drugstore that the patient is going to follow to prepare themselves for the lower GI exam. Preparation for patients with severe diarrhea, any gross bleeding, or if there's an obstruction, that would be different. That would be a very limited type of prep. As I mentioned, bowel cleansing methods, there are complete kits available. There's something called a GI lavage. Preparation of lavage is a cleansing with fluids, and cleansing enemas could be used as well. For the barium apparatus, you're going to have a disposable, small, soft plastic enema tip. They're available in different sizes. I guess I'm saying small, I guess it's relevant when you look at it. The smaller enema tips are available, and they're necessary for patients with any strictures, any fissures. Remember, fissures are breaks in the tissue. Inflamed hemorrhoids, which are those dilated varicose type veins that are the anal area, or other anal abnormalities there might be. Retention tips have a balloon cup at the end. That means there is a balloon at the end of the enema tip, and that balloon would be inflated with air after insertion. And the reason for that, that balloon then is going to go up against the internal sphincter, and hopefully then it won't allow the enema tip to be dislodged or pushed out during the procedure itself. For safety, that balloon is inflated using fluoroscopy just before the examination. Potential for intestinal wall damage if it's inserted or improperly inflated. So at many institutions, the tech is not responsible for inflating the balloon. It would be the radiologist's job, and as it says, it's usually done under a fluoroscopic control. There are special tips that are required for double contrast studies, because you're going to have to be putting not only the barium in, but also the air as well. Air could be instilled via a sphygmomanometer bulb, which of course is that bulb that's used for taking blood pressures. Enema bags have a 3-quart capacity. There's a filter that prevents passage of end-mixed lumps of barium. You wouldn't want going into the patient. That could look like something wrong with the patient. Tubing is about 6 feet long. There is a controlled clamp or a clip, because during the exam, the radiologist is going to be instructing you to open or to close the barium. Small bags, about 500 milliliters, with short, large diameter tubing, is available for double contrast procedures. As far as preparation is concerned, it's best always to follow the manufacturer's instructions. High-density barium is used for double contrast studies. The temperature of the suspension should be lower than body temperature, 85 to 90 degrees Fahrenheit. You never want to put any barium into a patient that's too warm. That could cause injury to the tissue. Higher temperatures are uncomfortable for the patient and less likely than to hold the barium. One thing that I do want to make mention of too, as far as the balloon, you often see this in register review books as far as a question about the enema tip itself. The maximum amount of air that can be inserted into the balloon itself is 90 cc's. So just put that little fact into your mind. The maximum inflation for the balloon is 90 cc's. Patient cooperation is key to success in this examination, probably more so than almost any other exam. Patient's got a lot of work to do in that they've got to be turning and they're trying to hold the barium. So it's very important that you, the radiographer, explain the role to the patient and what is going to be required of them. There are some ways that the patient can minimize discomfort. You can tell the patient to, relax their abdomen. Deep breathing will help when that barium is going in. And communicate to the patient that if cramping should develop, the filling can be slowed or stopped. Okay, a lot of times the patient will start to complain. The radiologist will tell you to turn the barium off. Without the barium flowing, sometimes that allows then that colon to just kind of relax. It's essential to allay any fears or embarrassment for the patient. Advise different ways of retention. Like I said, tell them they can deep breathe. Allow questions and provide answers as within the scope of practice, or refer to the physician, and then provide adequate draping for increased patient comfort. They're going to be doing a lot of turning on the table. They're going to have an enema tip in. They're not going to have any underwear on, obviously. So you want to make sure that you're always trying to keep them covered as best that you can as the tech to maintain their modesty. Be aware of the patient's strength, their condition, their age. The preparation itself, not eating basically, just fluids only can cause weakness. Elderly and infirm are going to require extra care and attention. They can't hold it as well. They usually can't turn as well as a younger person. You're going to have the patient go to the restroom to evacuate the barium. So make sure that you let them know that there is a call button in case they feel faint or any assistance is needed. And you always want to respect the patient's privacy, but inquire frequently on the patient condition. So, a little knock on the door every couple minutes, are you doing okay? It is very helpful. Enema tip insertion is very, very important. You don't want to improperly insert an enema tip into a patient and do damage to the rectal area. So the first thing that we're going to do is we're going to turn our patient onto their left side. Now, of course, we're going to use what's called the Sims position that we've learned about. So they're rolling forward about 35 to 40 degrees. They're resting on the flexed right knee above and in front of the left knee. This is going to help them to relax any abdominal muscles that may be contracted, decreases abdominal pressure, and it aids in the relaxation of the anal sphincter. You're going to adjust your IV pull height so the bag is no higher than 24 inches above the level of the anus. Once again, this is often a question you find on the registry. How high should the enema bag be? It's 24 inches, about 2 feet above the level of the anus. In putting the enema tip in, they're in the Sims position. You're going to expose the anal region only. You want to make sure that you have prior run barium through the tubing to make sure there's no air in the tubing before you're going to put that enema tip in. You're going to lubricate the enema tip. Usually some water-soluble lubricant is used. And then you're going to instruct the patient to take deep breaths. It's very, very important that you insert the tip slowly, okay, steadily, but gently during expiration of a deep breath. So you tell the patient, take in a deep breath, blow all the air out. As they blow the air out, you're going to start to insert the enema tip. You're going to direct it anteriorly, 1 to 1.5 inches, then slightly superiorly. So sometimes in books you see the wording, you're going to aim for about 1.5 inches. You're going to aim the enema tip towards the person's umbilicus. After you go 1.5 inches, and as it says, you're going to then turn slightly with the enema tip. It's going to follow the curve of the sacrum. But what's very, very important is the total distance of insertion, no more than 4 inches. You often see that on registry mock exams or in registry review books. Enema tips are never inserted more than 4 inches. The other thing that's of great importance when you're inserting an enema tip is you never force insertion. You may go to put the enema tip in and you're going to be inserting it and you're going to feel a lot of resistance. It's just not going in. Okay. At that point in time, you stop. Okay. You don't force an enema tip in. Now, you may ask the patient, as it says here, to assist. They can put it in because they're just clamping down. But if you're inserting it, there's resistance, the patient still can't insert it him or herself, then you let the radiologist know. Hopefully you got that enema tip in though, okay, and after it's inserted, hold in place while the patient then turns to the supine or the prone position. At this point in time, it says retention cuff may be inflated. Once again, most of the time, this is done under fluoroscopic control by the radiologist. One thing I'd like to mention, the enema tip is going to be in the patient. They're going to have a lot of apprehension. They're on their side, then you're going to tell them to lay on their back. You want to let them know that that enema tip is soft. It's going to bend. Okay, so a lot of times that gives them reassurance that they can lay on their back. Okay. You want a free tubing of any compression there might be to ensure that there's a free flow, so no kinks. For single contrast barium, you're going to enemas, you're going to introduce the patient to the radiologist. So once you've got them on the table, you've got the enema tip in, the radiologist is going to come in and you're going to say, Mr. Smith, this is Dr. Brown. On request, the radiologist is going to come over, is going to pull the image intensifier over the patient, take a quick look before any barium goes in, and then the doctor is going to tell you basically what to do. So on request, you're going to release the clip to allow the barium to begin to flow. The flow is suspended periodically to reduce cramping and defecation impulse. As the barium is flowing in, the radiologist is looking at the flow on using the fluoroscope, and radiologist instructs patient to rotate to visualize all portions of the bowel. So your job is going to be standing behind the patient with the clip in your hand on the tubing, and you're going to do whatever the radiologist tells you to do. Open, close. Once it's closed and then the patient is having to turn side to side, you can help the patient to turn as well. The radiologist is going to take spot radiographs as needed images digitally. Request subsequent radiographs if needed. So after the doctor is done with the fluoroscopic portion of the exam, he or she may say to you, okay, I want an RAO, an LAO, an axial view, whatever. Or simply the doctor may leave and it's the protocol of the institution that you're at to do a series of radiographs. After all of the images have been acquired and checked, you're going to remove that enema tip. Don't forget to deflate the retention tip or balloon first, okay, if it was blown up. You never want to try and pull the enema tip out when the balloon is inflated. So always deflate the enema balloon first. Assist the patient then to the restroom, instruct them to expel as much barium as they can. If they can't get up to go to the washroom, you're going to have to provide a bedpan for weakened patients. After the patient has evacuated, another radiograph is taken then to check the mucosa. That's called the post-evac film. So post meaning after, evac meaning they've let the barium out. They're never going to get all the barium out, so that's why we do a post-evac. If the evacuation is inadequate, the patient may be given a hot beverage for stimulation. That hot beverage is going to allow then for the peristalsis to kick in with the colon to help get more of the barium out, and then you might have to do a repeat post-evac image. Or double contrast studies. Double contrast is what's called the closed system or the Wellen method. A closed system does not require removal and reinsertion of the enema tip. Patients will remain on the table for the entire procedure. The Wellen method is recommended for detection of small lesions. For a single-stage closed system method, the barium is introduced and removed via bag position. So what that means is that the doctor is going to tell you, okay, open the barium is going to flow to a certain point within the colon, at which point then the doctor is going to tell you then to drop the bag to the floor. You're going to leave the clamp open, and what happens then is gravity is going to allow then that barium to backflow from the colon back into the bag. And you might say to yourself, well, then what are they going to see if the barium flows into the bag? Remember, this is going to be high density, thicker barium. It's going to coat the walls of the colon. So even though you're draining it back into the bag, you're still getting a very nice coating of the barium. Then the doctor is going to have you clamp the bag, and then usually the bag then is put onto the table. Then the radiologist is going to use that bulb, we mentioned like a sphygmomanometer bulb, and then it's going to then begin to put air into the colon. So air is introduced by bag inversion or by manual compression of a sphygmomanometer bulb. Bag inversion is rarely used anymore. It's where you can take and you can squeeze the air that's in the bag into the colon. Generally, it's that sphygmomanometer bulb that's used today. The Wellen method, barium is introduced to the left colic flexure, then the tip is removed, and then the patient evacuates. That means they may have to get off the table to go to the washroom, or you may have to have a bedpan. After they do that, the tip then is reinserted, barium is introduced to the sigmoid, and then air is instilled. So there's a little bit more to it with the Wellen method. Patient position altered to coat the mucosa. They're going to roll around, and then spot radiographs are taken as needed. Most of the time today we use the closed system. And there are various projections that are taken, a PA axial, a PA oblique, which RAO position and LAO position, lateral, AP, and AP axial. AP obliques could be done. This would be an RPO or LPO and an AP or PA with the patient in a right and a left lateral decubitus position. Essential projections for the large intestine. AP or PA, prone and lateral. There may be oblique positions, usually not. Usually your overheads. Now overheads, remember, mean after the radiologist has left, and then you're going to do radiography. They're generally done with the patient recumbent. In the second bullet here, it says positioning for upright positions are the same as for the recumbent, except the IR is going to be placed slightly lower to compensate for a drop of the anatomy due to gravity. For the PA or AP of the large intestine, patient position, they're either prone or supine. Heart position, MSP is centered to the midline of the grid. IR is centered at the level of the iliac crest. So you're going to go down MSP, level of the crest, and it's a perpendicular beam. And you're going to collimate to a 14 by 17 inch size. PA axial, patient would be prone because it's a PA. MSP in the midline, IR at the level of the iliac crest. For the PA axial, there's an angulation that's involved of 30 to 40 in a caudal direction. So for PA axial, you're using a caudal direction. You're going to enter the MSP at the level of the ASIS, and you're going to use that collimated field of 14 by 17 again. For PA obliques, which are RAO or LAO, it's going to be standardized depending at the institution you're at, 35 to 45 degrees. Memorize this, very, very important. RAO demonstrates the right colic flexure, the ascending colon, and the sigmoid. So sometimes you see in textbooks RAO opens the right colic flexure, which means when you're turning them, you're allowing that superimposition of the hepatic flexure area then to turn, and now you're seeing it or not superimposed. And then LAO would demonstrate the reverse, the left colic flexure, splenic flexure, and the descending colon. So RAO opens hepatic flexure, LAO opens the splenic flexure. For the PA obliques, heart position supported by the flexed knee and arm of the elevated side. MSP is centered to the midline of your table or grid. IR once again to the level of the iliac crest. The central ray is going to be perpendicular, and you're going to enter 1 to 2 inches lateral to the midline of the body on the elevated side at the level of the iliac crest. So imagine this in your mind. The patient is turned RAO. 45-degree oblique, your central ray is going to be at the level of the crest. And then what you're going to do is you're going to then move the central ray 1 to 2 inches towards the elevated side. What is that going to do? It's going to put the anatomy directly in the middle of your collimated 14 by 17 beam image size. For the lateral of the large intestine, recumbent, right or left lateral, just depends on the institution. The MCP or mid-coronal plane is centered. The knees are flexed slightly for stability. The shoulders, the hips, the knees are superimposed and they're perpendicular, and the IR is centered to the ASIS. Central ray is perpendicular. You're going to enter the MCP at the level of the ASIS. So imagine that your central ray is going to be at the level of the mid-coronal plane and then at the level of the ASIS. And because you're only looking at the rectal area here, in fact, most places call this a lateral rectum, you only need 10 by 12 inches of collimation. Axials are going to be used for the rectosigmoid area. You could do an AP or a PA. For the AP axial, which means the patient would be supine, you're going to have that MSP aligned to the midline of the grid. IR is centered to 2 inches above the iliac crest. So IR 2 inches above the iliac crest. And then you're going to angle now with a 30 to 40 degree cephalad angulation. So AP axial, 30 to 40 degrees cephalad. You're going to be entering the patient's MSP inferior to the margin of the symphysis pubis. So where the pubic symphysis is, then you would go just slightly inferior below that, and then you would angle in 30 to 40 degrees cephalic direction. And you're going to, of course, use a collimated field of 14 by 17 inches. AP obliques. Okay, so what did we learn? We learned that the RAO opened up the hepatic flexure. And then what's the reverse of an RAO? Well, that would be an LPO, so that too opens up the hepatic flexure. Remember, the LPO would be the mirror image of the RAO. So some places will do anterior obliques, RAO, LAO. Other places will do posterior obliques, LPO, RPO. It just depends on the institution. So as I mentioned, the LPO, which is the reverse of the RAO, would demonstrate the right colic flexure, hepatic flexure, and ascending and sigmoid colon. And then the RPO, which is the reverse of the LAO, demonstrates the left colic flexure, splenic flexure, the descending colon. You're going to have that MSP center to the midline, sponge supporting the elevated side, dependent knee is flexed for support, IR eccentric, once again to the iliac crest. Central ray is perpendicular. It enters the patient 1 to 2 inches lateral to the midline of the MSP, once again on the elevated side at the level of the iliac crest. So imagine that again, you got this 14 by 17 size collimated field. You're going to center at the level of the crest, but you're going to move the central ray then lateral about 1 to 2 inches on the side that's up. Once again, you're trying to put the anatomy within the middle or close to it as you can at 14 by 17. Let's move on to the decubitus views of colon. Very, very, very important. On double contrast studies, air or the upside is of interest. Okay? So if you think about it and you fill up the colon with barium, okay? Fill up the colon with barium, and you drain most of that barium and you put air into the patient. So you're going to have air and barium in the colon. Okay? Now let's imagine we're laying the patient on their right side, okay, right lateral decubitus. Okay? So think about your anatomy. Think about now where the ascending is, and think about where the descending is. Okay? So if I'm laying on my right side and I've got barium and air in my colon, if I lay on my right side, what's going to happen? The barium is going to level out, and then the air is going to rise up within the ascending colon. Okay, so you think about the ascending colon. If I'm laying, it's like a tube, and I've got one side filled with barium, the other side is filled with air. You're interested in where the air is, not the barium. So right lateral decubitus are used to demonstrate the medial side of the ascending colon. Now, think about you're on your right side. Think about where your descending colon is at now, and think of it like a tube. You're going to have barium leveling off and air rising. So we're interested in where the air is. So you're going to demonstrate then the lateral side of the descending colon. So right lateral decubitus, medial side of ascending, lateral side of descending. The lateral decubitus, left lateral decubitus, would then demonstrate the opposite. Okay, imagine yourself laying in a left lateral decubitus position. You're laying on your left side. Think about the anatomy, where your ascending is, where your descending is. Think of it, both of them as like a tube, and then think of it where the barium would layer out. It's heavy, and then the air would rise. So with the lateral, left lateral decubitus, you're going to see the lateral side ascending and the medial side of the descending. These 2 points are very, very important for you to memorize. You often see questions on tests and review books, registry, about which decubitus is going to best demonstrate what anatomy. So for these decubiti, AP or PA, the patient position the recumbent, lateral, back or abdomen is in contact with the grid. Part position, the body is elevated on a radiolucent support to center the MSP to the midline of the grid. So you may have to bring the patient up on a radiolucent sponge. And then once again, the IR is going to be centered to the level of the iliac crest. For the right or left lateral decubitus, the central ray is horizontal. It's perpendicular. It's going to enter the midline of the body at the level of the iliac crest. And you're going to use a collimated field 14 by 17. A question to think about. The PA oblique projection, the LAO, will demonstrate the blank. LAO will demonstrate the transverse colon, the right colic flexure, the left colic flexure, or the sigmoid. In a question like this, what I always tell students is, it was at least what I've done, I've memorized that the RAO always opens the hepatic flexure. RAO is hepatic. Well, what's the opposite of the RAO? The LAO, what does that open? Well, that's going to open up then the splenic flexure, the left colic flexure. So RAO is for the hepatic, LAO is for the splenic. Demonstrate the medial side of the ascending colon. So think about your anatomy, the medial side of the ascending colon and the lateral side of the descending. On a double contrast BE, the patient must be positioned in a blank. So I'm thinking about my anatomy. I'm thinking about these 2 sides as being tubes where the barium is going to go, where the air is going to go within that tube. And it says I want to demonstrate the medial side of the ascending. Remember, it's where the air is, not the barium. So if I lay on my right side, the air is going to go up to the medial side of the ascending and the lateral side of the. Let's take a look now at some images, some critiques of them. As far as the AP and PA, you want to make sure there's proper collimation, no rotation, vertebral column centered, so ascending and descending portions will be included. You want to see the entire colon, including the flexures and the rectum. And if it's a hyperstenic patient, you may need 2 IRs crosswise, so you don't clip off any of the anatomy. And you want to use an exposure technique that's going to demonstrate, of course, the anatomy. Here we've got a PA. Now, how do you know it's a PA? I want you to look at the iliac crest. And if you look at where it says it's identified here, iliac ala, notice how they look. Okay? It's almost like a line on each side. Because if you imagine a patient is laying on the table and now you're seeing these iliac ala kind of on end. Okay, so look, and if you see that appearance, where you see these iliac ala, that's like these lines, that's going to be your PA. Notice the redundancy or superimposition in this patient, especially of the left colic flexure, not so much the right, everybody's different, okay? But you got to eventually open up that left colic flexure and the right as well. Now look at the AP. Look at the wings of the ilium. Do you see you no longer see those lines on the side? Okay, because this is a cup-shaped structure on each side. The patient's not lying on the wings of the ilia. Okay, so you don't see those lines. Now once again, look at the redundancy or the superimposition of that colon. It's not like in a drawing where everything is separated very nicely. The colon's got a lot of areas where superimposition is taking place. Now your PA axial, now what's that for? That's for the rectosigmoid area. Evidence of proper collimation, no rotation. As I mentioned, rectosigmoid area is going to be centered. Rectosigmoid demonstrated with less superimposition than the PA. It kind of, what does an axial do? Axial projections stretch anatomy out. So it's kind of stretch out that rectosigmoid area. Transverse colon and the flexures are not necessarily included. So if you clip them, it's usually okay. And then exposure technique that shows the anatomy. So here we've got a PA of the axial, or PA axial of the large intestine. Notice a lot of distortion here, right? Because you're using that angulation to stretch out the rectosigmoid area. So we flipped the parts of the colon up at the top. That's okay. Remember, your rectosigmoid area, though, cannot be clipped. For the PA oblique projections, proper collimation, exposure technique that shows the anatomy. RAO, we want to see the entire colon. Right colic flexure with less superimposition than the PA. Ascending colon, cecum, and the sigmoid. So for the RAO, what are we going to open up the hepatic flexure? And then if we move on to the LAO, for the LAO, once again, we want to see the entire colon again. Left colic flexure with less superimposition than PA, so we're going to open the splenic flexure, and then see the descending colon. So here we've got an image, okay, and we've opened up the right colic flexure, so this is going to be our RAO. Look at the splenic flexure. Now, how do you know the splenic flexure versus the hepatic? Well, remember, on the right side, you've got your liver. And your liver pushes the colon down. Look at the level at where the right colic flexure is compared to the left colic, which is the splenic. So here, once again, we've done another PA oblique, and now we've opened up then the flexure very nicely. Look at the other parts of the colon, a lot of redundancy, a lot of superimposition. I would invite you to make sure that you look at the radiographs that are in Merrill's of the obliques, okay, and make sure that you understand that how, when you turn the patient, that you're opening or closing, I guess you could say, the flexures. Closing meaning that you're opening one, the other one's going to cause more superimposition. For the lateral of the large intestine, proper collimation, what are we interested in? We're interested in the rectosigmoid area. Okay, so that should be in the center. There's no rotation. Superimposed hips and femurs. Superior portion of colon not necessarily included, so if you clip it, that's okay when the rectosigmoid is of the primary interest. And exposure technique that will allow you to see the anatomy. Here is a lateral of the rectum. Now remember, these are usually on smaller size IRs. You're not looking at the entire colon, you're looking at the rectosigmoid area. Take a look at the image. You can actually see in this image the enema tip that has been inserted into the rectal area. And then you can see then how the rectum actually follows the curve of the sacrum. Okay, you can see the sacrum on the left-hand side here, and then notice how that rectum that's filled with barium here is just following the curve of it. Apiaxial. Okay, so if we don't do a PA axial, we do an apiaxial. It's going to demonstrate the same anatomy in that you're going to see the rectosigmoid area, but don't forget you got to angle the other way. Okay, so for your PA axials, we're angling in a caudal direction. For apiaxial, we're going to angle in a cephalad direction. So we want to see proper collimation. We want that rectosigmoid area centered with less superimposition than in the AP. How you're going to get this, you're angling. Transverse colon and flexures not necessarily included, so if we clip those, that's okay. An exposure technique to show the anatomy. Here is an apiaxial of the large intestine. Once again, that is stretching out. You can see it's identified the sigmoid colon there and how it stretches it out so you don't have that redundancy, you don't have that superimposition. AP obliques, some places do PA obliques, some places do AP obliques. Okay, it just depends. So if we're doing AP obliques, evidence of proper collimation, exposure technique that shows the anatomy. For the LPO, okay, so what did I say? Memorize that RAO opens the hepatic flexure. Just memorize that fact. Because if you memorize that fact that the RAO opens the hepatic flexure, you know the rest. Because you can say to yourself, well, I know that the opposite of RAO is an LPO. Well, then the LPO must open up the right colic or hepatic flexure. And then what do we have left? We've got two other obliques. We've got here, as it mentions, the RPO. And what's the reverse of the RPO? It would be the LAO. Okay? So memorize the fact, again, that RAO opens hepatic flexure. Say to yourself, what's the opposite of an RAO? An LPO. So it too must open up the right colic flexure. And what are my other two obliques that are left? The other two that are left are going to be the LAO and the RPO. And what do? They're going to open up the splenic or left colic flexure. So as it says here, LPO position, entire colon, right colic flexure or hepatic flexure, less superimposed or open as compared with the AP. Ascending colon, cecum, and sigmoid colon are better demonstrated. So LPO also demonstrates the ascending better. And then the RPO, entire colon, and you're seeing, as I mentioned, then the splenic or left colic flexure, and then the descending colon. There's a picture of the oblique. Here we have opened up then the hepatic flexure, you can see. Okay, so this would be what opens up the hepatic flexure. Remember, open hepatic flexure is RAO, or if it's an AP, LPO. There's the other oblique then, opening up the splenic flexure. Let's move on to the decubes then. Finally, the right lateral decubitus position, evidence of proper collimation. You want to see the area from the left colic flexure to the rectum. It's a decube. It's a lateral decube, so you don't want rotation. And this can be evidenced by symmetry of the ribs and the pelvis. Single contrast, you want to make sure you penetrate through that barium. Double contrast, air side of interest should not be over-penetrated. Left lateral decube, once again, evidence of proper collimation. Area from left colic flexure to the rectum. No rotation, evidence by symmetry of the ribs and the pelvis. Single contrast, barium penetrated, and double contrast, make sure you don't over-penetrate that air. So here we've got the colon demonstrated in a right lateral decubitus position. Okay. Now there's still a lot of redundancy and superimposition, no doubt, right? Okay. But what is of interest, you can see how that it is that barium is actually layering. You can see those fine levels, straight levels there, and then you see the barium then rises to different portions. It's those portions that are filled with air that are going to be of interest. Notice the marking the tech put on there, left with an arrow up, which would indicate this is the left side up, which means patient's laying on the right side. This is a right lateral decubitus. Here we've got then the left lateral decubitus. Notice the right side up as well. Once again, you can see the layering of the barium. Okay, we're not interested in where the barium is. We're interested in where the air is. Okay. So this would be then your left lateral decube.